Good day. This is Charles Denham, and I'd like to welcome you to our High Performer TMIT webinar series. And today our topic is Update on CPOE, Health Information Technology and Using Simulators. And the second topic focused on SpeakerLink and patient engagement, bringing patients and families into your healthcare system. It is a real pleasure to have a terrific group join us. I just want to cover a couple of housekeeping details, and for those of you that are on the slides, I'm in the third slide, and I'd like to remind everyone to make sure that you have your speaker volume on full. If you have audio difficulties, then you can click down in the lower left-hand corner of your screen and request a phone line. So make sure to get your speaker volume up and then do that. On slide 4, for those of you that have the slides and those of you that don't, if you go to safetyleaders.org, www.safetyleaders.org, in the upper right panel, you'll see in the upcoming events a place to click on, and in that location you'll get a link that will take you to a page that will allow you to download the slides and in future listen to the webinar again and also have the content available so that you can review it in future. Also, on slide 6, you can follow us on Twitter and Facebook, and you'll see the coordinates there on slide 6. Slide 7, we just want to remind you of our calling, which is to accelerate performance solutions that save lives, save money, and create value in the communities we serve. Slide 8 has a disclosure statement, which I won't read for you, but please review. And we will not be discussing any products or services for which any of the speakers have any association. These things being said, I'm on slide 10, and I'd like to invite Regina Holliday to open us with a message from patients and families, which we love to do on each of these webinars. Regina?
Hi, everyone. It's such an honor to be here again today in December. Once again, wishing everyone happy holidays. And the patients and families that are out there so appreciate the work that TMIT and SpeakerLink has done to promote patient safety, greater awareness of data access, medical error, and everything you do helps those of us, especially this time of year when we miss the loved ones that we have lost.
Thanks very much, Regina, and it's great to have you being such a steadfast advocate for patient engagement and out on the circuit there helping us in every way you can, and we really appreciate it. SpeakerLink, the second section that we'll cover today, really resulted from a meeting that you and I were at with Tricia Torrey, who's another speaker today, and so we're excited to have Dr. Dave Classen, who will speak right after me, Dr. Bruce Ramshaw, Tricia Torrey, two of our own, Matt Lestiak, Colin Gabriel, and the third is Amira Allison, who will be with us speaking and representing the team that's helping develop SpeakerLink as a patient engagement tool and framework. So we're really excited to have this group and two topics. Now, what I'd like to do is just take our group back. For those of you that have been with us on our High Performer series, in the end of 2012 and during 2013, we have been working with our National Research Testbed and asked our testbed and surveyed them on the top 10 leadership issues, top 10 practice issues, and top 10 technology issues for 2013. We've continued to pull you throughout the year on these topics, and I just want to refresh you and reaffirm that we really haven't had anything new pop up in the top 10 of either of these. So you can see on this first slide, the leadership targets for 2013 really, and I won't read it for you, but you can see that involvement of the C-suite is really a high topic area. Now as we have consolidation, and as I speak to you at the end of the session regarding our January webinar, we'll be addressing how to get the C-suite really engaged and involved in infections. And we'll have Dr. Classen back also in the first quarter. He has both expertise in medication management and the HAI issue. However, as you look through these, we did not see anything that were new, and you see a lot of focus on leadership. Care of the caregiver has continued to be important, but with consolidation, we definitely see a lot of the topics that are really important to the C-suite, to safety officers, that the C-suite really become engaged. As we look at the practice targets, the targets of greatest interest, we have the issue of surgical never events became a pretty hot topic. However, we had the surgical events had just been released at the time of that survey. It may have skewed the numbers, but we still see this to be a major issue. Availability of healthcare and medical records, very important. Prevention of HAIs continues to be really important. Pain management, end of life, critical, sepsis critical, safe blood management, failure to rescue, all of these have continued to be important. I think that the overuse, underuse, and misuse of different products, services, technologies, diagnostics has probably moved up the chart some in our dialogue. And now I come to the subject at hand to really introduce Dr. Dave Classen. I think just one of a real national treasure in the area of health information technology, medication management, health associated infections. To lead into that, we're really addressing today health information technology. A net promoter score of 74, amazing. 59% of you said that health information technology with the electronic healthcare record and IT systems, 59% said it was top, gave it a 10 as most important, or not most important, but a 10 as very high importance. You could give a 10 to everything if you thought they were high. So in the top 10, 59% of you said that it was a 10, very high. We're going to pull you again at the end of this session, but we find this to be a really key issue, and that health information technology accidents, the importance of CPOE, really critical. 22% gave it a 9, and then 12% gave it a 7 or an 8, and only 7% of you gave it between a 1 and a 6. Interestingly, the second most frequent topic was interoperability failures with HIT. So HIT actually scored in the top 2 of very high importance. And then as you see the other topics, medication management with pumps, alarm hazards, and a number of issues as we come down the pipe. So very, very high importance. This is just a bit of a refresher on the National Quality Forum Safe Practices. There was the 2003 report, 06, 09, and 2010. And we had the honor of working with Dr. Classen and Dr. David Bates to focus on CPOE in this group. Now this slide, the background slide, is the Institute of Medicine, and the IOM, and Dr. Classen was a great contributor to that group, as well as Dr. Bates and Dr. Bajan and a number of leaders in HIT, identified that the simulator, the TMIT simulator that we provide to the Leapfrog group for transparent measurement of CPOE should be a national standard. And there continues to be very heavy dialogue on this measurement system and test that Dr. Classen will cover being absolutely critical. Safe Practice 16, David Classen, David Bates, and others and I wrote this safe practice in the 06 update to the National Quality Forum Safe Practices. And then we added to it the measurement, post-deployment measurement of CPOE. So I'm not going to read the slide for you. It's there for your background. But we addressed the staged approach to CPOE. And as you see in the bottom part of this chart, this slide, that we use the flight simulator that TMIT provides to the Leapfrog group as a national quality forum standard. So then leading into Dr. Classen, we wrote an article in the first part of 2012. It was published in the Journal of Patient Safety. Full disclosure, I'm the editor-in-chief. And our co-authors, Dr. Classen being really a fundamental contributor, as was Dr. Bates, we all wrote this article together as a team. But you'll also note that the former head of quality for the Mayo Clinic, currently the head of leadership and development, Dr. Steve Swenson, and the head of quality for the Cleveland Cleveland Clinic. We're both co-authors, as is my assistant editor of the Journal of Patient Safety, who is the global envoy for WHO. So this represents real consensus on this effort. So as I turn things over to Dr. Classen, I'd just like to tell you where we're going with the simulator. And where we're going with it is we started with acute care hospitals. You see in the upper left quadrant of this graphic. And we will be updating it for 2014, dramatically updating the panels of patients and the process and how it works, expanding it to ambulatory care, expanding it to radiology, expanding it to laboratory, and we also will be expanding or updating and expanding in the pediatric area. So Dr. Classen and I have been over the most recent results provided to us by Leapfrog, and Leah Binder will be a co-author of an article that will address this. And as a setup to Dr. Classen, this graphic representation basically says of the 5,000 or so hospitals in America, and we all count them differently, we could call them between 4,000 and 6,000, HIMSS told us that roughly 50% of them have implemented CPOE. So we don't have an exact number of hospitals, but let's say it's 50% according to HIMSS. We do know that this year in 2013, 847 submitted to a Leapfrog, and over 2,100 did not. And Dr. Classen will go through a waterfall chart that we created to give you the fractions of this group that ultimately have submitted. And right now, this week, we're actually analyzing the data of those submitters. So with that introduction, I'd like to turn it over to Dr. David Classen. Dr. Classen is an associate professor of medicine at the University of Utah. He's been on many NQF and IOM and CMS panels. It's been a real pleasure to work with him hand in glove in this area of medication management. Most people don't know that Dr. Classen also was really a real leader in the harmonization of healthcare-associated infections compendium. So he's behind the scenes been a terrific contributor and a servant leader in this space. So Dave, would you take it away? He may be on mute, and just so we can keep going, I'll cover for this until Dave is on. I don't hear his voice coming through. Kyle, let me know by IM or email when he does. This graphic is actually a graphic that came from the collaborative work across the board with IHI, with the VHA, and with a number of organizations. And you see in the upper right-hand quadrant of this slide the articles from Dr. David Bates and Dr. Leap and Dr. Classen. It's a complicated slide, but if somebody said, give me something on one page that helps me understand adverse drug events and errors. If you look up in the upper left-hand side of the slide, you see history taking, obtaining medication-related history, documenting the history, and then moving to ordering. The prescribing errors are about 39% of errors, but about 49% of adverse drug events that cause harm. If you look at transcription versus ADEs, they're almost about even in the transcription phase. And then when you go down to pharmacy management, about 14% of the ADEs and 11% of the errors occur there. When we come to administration, you see that administration errors are 38% of the errors and 26% of the adverse drug events. Are you there, Dave? I covered for you on this slide. Go ahead and take it away.
Yes, thank you very much, Chuck. So as Chuck is outlining, the reason we're so focused on computerized physician order entry as a safe practice is because half of all the medication problems we have in hospitals can be prevented by this critical safe practice. And if we look at the very latest studies on all-cause harm in hospitals, the largest category remaining is still medication-related safety issues. So that's why this is so critical and so important and such an incredible opportunity for improvement. So the fact that 49% of medication problems can be prevented with CPOE is why we're so concerned about it. And the data to date suggests that, and we can move, I'll advance it, Chuck, if I control it, I do. The data to date suggests that just because you put an EMR system in with CPOE doesn't mean you have the appropriate safety best practices implemented to actually reduce that harm in the hospital, which is the biggest category of all-cause harm. And studies that we're going to present to you now show that if we do test EHR systems after deployment, we find that the way they perform is not the way we think they're performing. And therefore, we can use that information to optimize our performance and reduce the harm in the hospital. And there have been several studies that have shown that in hospitals that have all electronics in place with an EMR and robotic dispensing and everything else, they can still have very high rates of medication safety problems. And it's because they haven't evaluated the performance of their systems and optimized it with what we call clinical decision support to have the greatest impact. So that's the reason for all of this, and we all wrote an article Chuck mentioned saying that we can't assure the safe use of electronic health record systems unless we test them after deployment, which is basically what this safe practice is all about. And so what we've done in this safe practice is allow a way for hospitals to measure how safe the use of their electronic health record system is after implementation. And we do that through a very simple mechanism, which is we've created a series of simulated patients and orders that are standardized, that can be easily downloaded from the net and placed in the EHR CPOE system as a way to test how well that system in actual operation picks up problems. And in this example, this would be a patient, as you see on the left, a woman who's 52 years old, weighs 60 kilograms, is allergic to morphine, has normal renal function, and we order Coumadin in that patient 5 milligrams 3 times a day. What we do is observe whether the operational system actually picks up this as a problem. And so when we do that, as you'll see, we find that not every system is picking up what we think it would pick up. Every system should pick a problem up with this order, but many do not in actual operation. And we know from other industries that these highly complex, dynamic, adaptive HIT systems need to be routinely tested in operation to ensure that they're functioning safely. In the aviation industry, flight management systems are tested all the time. In healthcare, if we have our EMR shut down and crash, we don't bring it back, take it out of service and retest it. We bring it right back up and start using it again. So we're clearly very different in how we test operational IT systems after use. And this test was based, as you can see on this, actual research databases that have tracked orders in HIT systems all the way throughout the process and documented harm that's occurred to patients. So this test is not based on run-of-the-mill medication errors. It's based on adverse events that have actually occurred to patients and been documented in a series of databases we've used to develop the test. So as such, a recent article by David Bates found that there was a direct relationship between how hospitals do on this test and how well they do at preventing actual adverse events that occur to patients. And that was the whole goal of this test, not to focus on run-of-the-mill medication errors, but only to focus on those errors that really count, the ones that really cause harm to patients. So this paper validates the fact that this test addresses just those things that cause harm to patients. And when hospitals take this test, they basically download the simulated test patients, simulated test orders from the internet. They enter them into their system, and then they record and feed back to the test how their system performed in picking up these unsafe situations, their operational systems. And then we give them an overall score on the test, and we also break those scores down by category. And so categories can include therapeutic duplication, which is how well does an installed EHR system pick up ordering medications that are in the same class, maybe not exactly the same medication, or how well do the installed EHR systems pick up critical drug allergy problems, how well do the installed systems pick up critical drug-drug interactions, how well do the installed systems pick up what we call drug renal, which is adjusting the dose of medications for patients in renal failure, or how well does the system pick up critical drug diagnosis issues, i.e. ordering a drug that would harm a pregnant woman. So that's the categories of the test, and we now have information on that test over a 5-year period. But this was a study done with information from that test. The first year it was available in 2008. It looked at 62 hospitals that took the test in 2008 and their results. And what was fascinating about this is these 62 hospitals were pretty progressive organizations, tend to be larger hospitals with sophisticated informatics departments, tend to be larger hospitals with sophisticated safety programs. And we were very interested in how those hospitals would perform on this test, tended to be more academic than community, et cetera. And what we found is that the variation in how these hospitals performed on this test was stunning. In the group of 62, the highest scorer got 82% of these simulated safety problems detected and prevented. The lowest scoring, only 10% in some hospitals that took it, picked up all these simulated safety problems. So a huge variability. A component of the test is orders that will kill patients reliably. So we call them fail orders. And if these orders were to run through a system, they would very likely kill a patient. It's a subcomponent of the test. What was really interesting is when back in 2008, in these 62 hospitals, only 53% of those fatal orders were actually picked up by these hospitals' operational EHR systems. So that was a cause for a serious concern because all of those hospitals, I can tell you, thought when they bought and installed their EHR, it would have scored 100% on this test. And so I think we found that there was a lot of variability in how hospitals did on this test, and that variability was so great that when we lined it up on this slide by vendor, it was amazing how much variability we found. So basically on this slide is the performance of hospitals on this test organized by the vendor that they had implemented. So vendor 1, vendor 2 would be a large commercial vendor, vendor 3, vendor 4, vendor 5, vendor 6, vendor 7, vendor 8, all different large commercial vendors, and the boxes represent hospitals who had implemented that vendor product and how they did on this test. Vendor 1 was a homegrown system in Boston, and we used that as a control to see how well that did versus these. And you can see, number 1, the homegrown system in Boston did far better picking up these safety problems than any of the others. But the most stunning thing about this chart is that the variation within vendors was much greater than the variation between vendors. And the lesson there is that in terms of safety performance, it's far more important how you implement the vendor product rather than what vendor product you choose. And so that led directly to a lot of concern that we have no way to look at how hospitals or health systems or clinics actually implement these products. All of our certification and everything else is focused on the vendor and their product on the shelf. We don't have a way to measure the performance of these vendor products when they're actually implemented in hospitals. And so there could be a wonderful vendor product that looks great on the shelf and performs very well on the shelf. When it actually gets implemented somewhere, it could perform very poorly, or it could perform very variably, as that slide shows. So this has caused great concern, obviously, as meaningful use has led to a rapid adoption of electronic health records, electronic medical records throughout the United States. And when we look now, about half the hospitals in the United States, based on the HIMSS databases where this is drawn, have implemented at least at the stage 4 level or below, which means that they have CPOE in place. So, roughly 2,500 to 3,000 hospitals in the United States have implemented CPOE in their hospital. And the question is, how many of these roughly 2,500 to 3,000 hospitals have actually taken this test to assess how their implemented operational CPOE EHR systems performing. And in 2013, you can see that only 847 have even taken this test. So there could be as many as 2,200 hospitals in the United States that have implemented CPOE that have no way to test how safe that system is in actual operational performance. And when we break down this group a little bit further, we find that of the 847 who submitted in 2013, 177 of those hospitals were ones that have been taking the test since it first became available in 2009. And as of 2013, another 670 have been added. But understand that that's still a small percentage of all the hospitals in the United States that have implemented CPOE based on estimates from the from HIMSS. And if we look at those 177 original submitters who started in 2009 and taken it every year, many of them take it twice a year, because many of them believe that that you have to have ongoing post-deployment testing of your system to ensure that it's performing safely. And what we found is there's a lot of variation in those hospitals. They can do very well in one year and not do so well in the next. And that points out that these EHR systems are highly complex adaptive systems. They're changing all the time, and performance can change, but if there's no way to measure it, hospitals have no idea what's happening. So just a story about that. I've been to some of these hospitals which have implemented very complicated, very dynamic EHR systems with CPOE, and they pick up all sorts of safety problems routinely in operation. But I've been to a couple where we sent fatal orders right through the whole system, and what had happened is that when these systems were initially implemented, they were designed to pick up those fatal orders, but every time the organizations do an update, it leads to unpredictable changes in the system. And so I've been to several where they thought they were picking up fatal orders. We actually put them in, they went right through the system. So the point is these are highly dynamic systems. You cannot predict just because you put it in 5 years ago and it would perform well then that it's performing well now. So if we look at those 177 original submitters, 55 are academic organizations, and the rest are non-academic organizations. Gives you an idea of the breakdown. And interestingly enough, only 9 of those hospitals that are submitters since 2009 are on the U.S. News and World Best Hospital Report. So there may not be a whole lot of correlation between that report and people who actually take this test. So with that, I will turn it over back to Chuck, and Chuck, you can move to the next group. And I think Matthew's up next.
Chuck, maybe
Thank you, Dave. I appreciate it, and I've just sent Kyle our polling questions for the EHR portion, which we'll have at the end. It's a great pleasure to introduce Matt Listiak. He's our senior producer at TMIT, and we worked all together as a team on both of our Discovery Channel films, Chasing Zero and Surfing the Healthcare Tsunami, Bring Your Best Board, and Dr. Classen was one of our experts on that film, as were so many that are on the program. And we'd just like to remind you, as we introduce Matt and the team now, to shift over. Now we're shifting over to patient engagement and the value of really bringing what we call seekers, those that would like to or start bringing patients and families in to tell stories that will help an organization with their culture and move the heads and hearts of their teams, as well as the speakers. So there are the seekers and the speakers that we'd like to bring together. And we did address that this area in our second Discovery film. And our third film will be addressing healing moments, loved ones caring for loved ones, and we'll really use the power of stories there. So we're really thrilled to have Matt take over this section with Colin and Amira, his colleagues here on our West Coast office, and host this section. So Matt, please take it away.
Thanks, Chuck. So this section, we're going to talk a little bit about SpeakerLink and also engaging patients and bringing them into your organizations from a clinical perspective, as well as the perspective of a patient who's had a lot of experience doing this and partnering with healthcare organizations. Some of our objectives, we hope that by the end of this section you'll feel comfortable making patients part of your meeting, because we know there are barriers, including concerns over negative experiences that patients may bring into your organization. There could be cost issues as well, and even the appropriateness of the patient's presentation. So we're going to address a lot of those in this section. We hope that you will invite someone from your community to come speak at your organization as well. And you'll also know one of many tools that are available, which is SpeakerLink, that might help you find the right speaker, which is, of course, critical to find the right person for your organization to bring them in. And then we hope that you might join us not only as a speaker using the tool, but potentially as a speaker as well. SpeakerLink is designed to be an open system that allows anyone to join, and that way we can find the right matches for people. And finally, we want your feedback. So we're looking for things that you might be looking for in speakers, maybe even some advice that you as clinicians and patient safety leaders would want to pass on to speakers so they know what you are looking for in a speaker. That two-way communication is extremely important to help develop the speakers so that they can come to your organizations knowing how to interact with you and vice versa. So please feel free to send us any advice and feedback to speakerlink@tmit1.org. So we're going to hear from two speakers today. The first is Dr. Bruce Ramshaw, and just to give you a little background on Dr. Ramshaw, he's the founder of the Transformative Care Institute, an academic medical center in Daytona, Florida, which you'll hear about a little bit in a moment. And he's also been an entrepreneur. He started several companies in the healthcare field, author of several patents involving medical education software and devices. He's traveled the world teaching and performing laparoscopic and advanced hernia procedures. And in addition to his private practice, he also served as the chief of general surgery at the University of Missouri, where he started to see the potential for this new model of healthcare where you implement patient-centered care teams, which is what he will be discussing. Currently, he's pursuing that model of care at the Transformative Care Institute that he founded, and this has the honor of being the first academic medical center in the country to be designed with divisions based on patient problems rather than physician specialty. So it should be an interesting perspective, and with that, I will hand it over to Dr. Ramshaw.
Thank you very much, Matt. I appreciate the opportunity to speak with you, and I look forward to any and all feedback. As Matt mentioned, we have gone through the past 10 years of trying to learn about how we could redesign healthcare. And it's a work in progress, I'll tell you right off the bat, and so any feedback is greatly appreciated. But there is an evolving science behind complex systems or complexity. And as I learned that science, as we all learn that science together and work to apply it, we learned that really it's critical to include the patient and family as part of not just getting their own care and feedback, but actually including them in the clinical care of other patients, the education of residents, and in the research. And I'll talk about that after I introduce a little bit of the foundations of the science behind complex systems. So this is one of many graphs that we see about the per capita spending in healthcare, and you can see, as everyone knows, the U.S. has more spending. But if you look at the slope of those curves, you see that all of the fragments in our system, the medical device companies, pharmaceutical companies, hospitals, physicians, they're all doing their job very, very well if their job is defined at increasing growth and increasing revenue, because all of the countries, all of the developed countries, are on an unsustainable path. And to understand if the fragments are all just maximizing their growth and revenue, this is a predictable result, and it's not sustainable. Part of the understanding from complex systems is the results are produced by the design of the system. So a system is designed to produce the results it's designed to produce. And in our healthcare system for patient care, that's essentially the hospital structure and the physician structure. And part of the increasing complexity, the result is an increasing bureaucracy. So this is a reflection of concept at the front line. There's 100% knowledge of what the patient care is like, but as you go up the bureaucracy, there's less and less knowledge of what's actually happened on the front line. And the other structural result of increasing complexity is more and more fragmentation or silos within an organization. And we see that in hospitals with so many different departments. And unfortunately, they end up competing for resources and not communicating well. And it's the patient that goes between all these silos, and none of the resources are are designed and applied to the patient process or cycle of care. And with all these fragmentations, with the increasing complexity, we end up with the concept almost that we're competing. We're competing for resources. We act as if we're not all in this together, and in reality, we are. The other structural issue with increasing complexity is the physician practice, the independent model, where the individual physician is expected to care for patients and have enough knowledge and resources to make the right decision, tell the patient what they need based on their presentation, and I think it's getting clear this model is also not sustainable. This is the date, apparently, that the 20 millionth article in PubMed was published, and there's an article published every minute. And I think it's clear that nobody can read that fast and keep up with all that knowledge. This is a primary care study that shows the red spikes are how much medical knowledge is required to give a best treatment plan based on a basic set of symptoms. And you can see that top green line is the maximum human cognitive capacity. So we have long gone past the realistic ability of human beings to get enough information in our head and give this kind of treatment recommendation. And really, this is based on the time of the Renaissance, what's called reductionist science. It's a picture of Isaac Newton and a representation of the scientific method. And this worked very, very well in our world for a long time, and we've applied this thinking and we've applied this science to our organizational design and structures. But with the increasing complexity, it's just not keeping up. The concept is basically that for a basic, simple system, that there should be a direct cause and effect. And if you do something, you should be able to predict the result. And that doesn't work out so well in the real world of biologic healthcare. We are complex systems, and we can do the same exact thing in two different people and have different results, and that's really the difference. And so what we have learned through evolving that more complete science is that we aren't machines, but better metaphors of complex adaptive systems, and that means we're going to have to change how we think and how we design our, in this case, our patient care. And that's what Einstein was talking about 100 years ago. And he said, we're going to have to change our thinking if we're going to solve the problems that are going to be created by how we applied that reductionist science principles to our organizations. And so this is now our attempt to take this more complete science and apply it to patient care, where we design multidisciplinary teams around the patient and the patient-specific problem. In our case, for our first program, it's based around abdominal wall hernia disease. So in hernia care, we use plastic mesh to fix hernias. So we need a materials engineer. We have organizational design psychologists. We have engineers and doctors and patient care managers. I'll talk a little bit about that. And we have patients and family members participating not just in the clinical care, but also in the education and research. And this is a TEDx talk that I gave last year talking about this model. And in the slide on the back, you can see one of our patient care managers with one of the patients, and she has a neck brace on. She had a hernia repair, but during her recovery, she fell and broke her neck. And the point was, we didn't say, oh, now that's the spine surgeon's problem, but the patient care manager continued through that entire cycle of care with that patient, even though it was a broken neck that became her main problem. And that's a key role. The patient care manager helps with the local process management, but also develops a loving relationship with patient and family. I think this is how we get that engagement, by having a role where on the team there's a local manager who works with the patient and family and develops a true human, authentic relationship. And then communication is a lot easier to have when you have that kind of relationship. Our first patient and family committee meeting was about 4 or 5 years ago. And we asked the patient and family who on our team actually provided their care. Who did they think provided their care? And it was surprising a little bit that actually the surgeon, they felt, provided less than half the care. And the care was provided by a variety of people on the team, but primarily the patient care manager provided a very large portion of the care, especially when the patient had a complex problem. And we have included patients and family members on our care teams over the last few years. This is one of the patients that we saw. He was an NFL football player, and he suffered from chronic pain after an inguinal hernia repair. And unfortunately, through a surgical procedure, he got better. And this doesn't always happen, unfortunately. But he has helped to counsel dozens of patients over the last several years. And in some cases, he's actually taken a patient suffering from chronic pain, and through that relationship has helped them relieve their pain just through talking with them and sharing his experience. So it's a pretty powerful part of the team when former patients help current patients avoid surgery or other procedures. We also have a former patient who's part of our team is Jerry Berlin. He was an aviation safety expert as an organizational design psychologist, and he was a hernia patient who now has become part of our team and helps guide us, applying some of the principles he learned and applied in aviation now with our team in healthcare. And we also have begun to use experiences of patient and family members as part of our education. We started a general surgery residency program last year, and this is Dale Michelizzi. She had a son, Justin, who died of medical error, and she gave our very first grand rounds last year. It was very powerful. And Regina, who's on this webinar, gave the grand rounds for our residency program this year. And again, incredibly powerful speaker and story and message for our general surgery residents. And that's one of the paintings she painted for our program. I also was privileged to become part of the walking gallery. And the pictures of me at the American College of Surgeons this year, and I got to say I was kind of lonely as the only surgeon there with a walking gallery jacket. But I hope in the next few years there'll be more and more. I was also program director of the American Hernia Society this year, and for the first time in this society, I had patients and non-physicians give talks at the podium. On the right, there's a patient who suffered with chronic pain after hernia repair, and on the left is our patient care manager. I've got to say, it was an uncomfortable time for me. It's kind of scary for a surgeon and someone in a leadership position to have patients give talks to hundreds of your colleagues, but I can tell you it was very well received. And then finally, I'll talk about the research that we're doing. And with care coordination and clinical quality improvement research, I was shocked when I read the HIPAA law and how supportive the laws are of these concepts of coordinated care involving the patient in the care and performing continuous quality improvement research. And these laws very much support these efforts. And for clinical quality improvement, we have this multidisciplinary team. We define the patient's entire cycle of care, and we look to measure value-based outcomes. And many of you are familiar with the PDSA cycle, but we've added the part where the patient and family and the multidisciplinary team gets together to look at the data, brainstorm, interpret the data, and then try to apply it and act on it. And we do this regularly. We don't have patients and family members on every CQI meeting, but we do regularly have them involved, and they have added a significant amount of value in our ability to come up with ideas and improvement ideas and try to apply those improvement ideas. So in summary, I think all of us in healthcare truly care. I'm sure those of you that are spending your time on this webinar are here because you care about improving care of the patients. But I think we still have trouble not knowing how to improve the value of care to the patient. But I think we can learn to do that. I think we will need to change our thinking and our system structures for how we provide care. But I think the most important thing for this message is that we can't do that without patients and families involved. And again, thank you very much for the opportunity to share some of our experiences. I look forward to the rest of the webinar.
We might be able to expand on that and hear a little bit of the lessons learned and things like that. And now we're going to hear from Tricia Torrey, who is, she's known as Every Patient's Advocate. She's also About.com's expert in patient empowerment. You can read some of her great articles there, some really good information on About.com. She's authored 3 books. She's a national speaker who focuses on communicating with patients, helping providers, improving outcomes and experiences
by including patients into the healthcare system. She's been a part of SpeakerLink since the idea was conceived, and she's going to discuss some of the reasons that you and your organization can benefit from engaging patients to further your goals. So, Tricia, it's all yours.
Thank you, Matt. I am very excited to be here. It's been about 2 years since we started talking about SpeakerLink, and I'm thrilled to have some success stories to tell 2 years later. So I appreciate the invitation to be here today. I want to talk about the fact that patients make great partners. From the speaking I have done, both speaking to patients and speaking to groups of providers, I've learned that there's some trepidation actually on both sides. It's like everybody's a big stakeholder, but everybody's afraid of stepping on other people's toes. And there are an awful lot of people who think that they should have a lot more say than somebody else. But that doesn't always do all of us good. And I loved hearing what Dr. Renshaw had to say about including patients in the various things that you do in a hospital or healthcare setting, because I think it's communication and understanding everyone else's points of view, and then using those points of view to move all of us forward that helps everyone. So let's start with patients make great partners. And we need to advance the slide here. I think, Kyle, you're advancing them, or am I? There we go. Okay. So patients do make great partners. They can be included on anything from advisory boards to boards of directors or boards of trustees, depending on what your hospital has. And they can also be speakers at provider or board programs. Sometimes it's just great to invite them in for a conversation, whether they're sitting on a board or you just want to talk to them about the experience they have. The thing is, what's important about this is that all of our interests are well aligned. Your patients come in, what they want is satisfaction. They want safety and security, they want healing, and they want peace of mind. Well, you in the hospital want the same things. You want to please your patients. Certainly you want to please them because it's a lot nicer having them go out the door with smiles on their faces and having their families with smiles on their faces. But you also now are tied into patient satisfaction scoring programs and income as well, and so therefore you want them satisfied from those points of view as well. You want your patients to trust you for a number of reasons, not the least of which, if they trust what you're telling them, they're more apt to be compliant. And when they've been discharged, to be compliant is also a good thing, or adherent. I know that's the right word now. You also want your patients to be safe and secure because that's good for your hospital as well as for them. If you let patients help, if you let them into decisions that are being made, or at least input to decisions are being made, there are some great outcomes. You can increase their satisfaction, as we talked about. You can also improve their safety, reduce errors. You may even reduce costs. And so if I can give you a couple of examples here, reducing or improving safety sometimes can be as simple as making sure that there's a family member, a loved one, or a private advocate sitting by the patient's bedside, in which case in comes someone to help them out, and the person sitting by the bedside says, will you please wash your hands? Make sure that your hands have been sanitized. That can help prevent infections. You can also, my dad was in the hospital about 1.5 years ago. I sat by his bedside. He decided to get up after surgery, and I kept him from falling. And so just the fact that you've got people there, that you value the fact that they're sitting there, they can help out, you are going to reduce errors and improve safety. You can also reduce some of the costs. Certainly, if a patient is harmed, that's so expensive to you. So having someone there by their bedside can also help. Some hospitals, I know, are a little bit leery about inviting patients in to help out, and they ask me, isn't this a little like asking the inmates to run the asylum? Yes and no, but in this case, I would like to say that the inmates probably have some information that can be used by you. First of all, your patients and their caregivers and family members are on the front line of what's happening in your hospital. On the front line, they can actually see what's going on, things that you may not be aware of, particularly things that some personnel may be trying to cover up. And they can report back to you if they know that they can trust the person they're speaking to. They'll share the good and the bad with you. But the key is you need to ask them to provide feedback and ideas. And when you ask them, it indicates you're listening. But even the bigger key is that you do need to listen. Lip service doesn't just cut it. So just providing somebody who's going to listen to what they have to say, maybe take some notes, and then not taking any action afterwards isn't going to help you at all. Now, what I'm familiar with is that many hospitals are worried about having angry patients and asking them to provide input. And of course, angry patients aren't good for anyone. You don't want or need an angry patient advising you. And you know, frankly, as a patient myself, I don't want to be represented by an angry patient. I myself work in the healthcare environment and in patient empowerment and advocacy specifically because I had my own very negative, horrible run-in with the healthcare system in 2004. I could have gone off and spent the rest of my years being angry and paying that price, but instead I chose to go forward and try to help other people learn how to get themselves through the healthcare system more successfully. And I learned from that what I needed to be doing was working to collaborate with providers, make sure the communications were very strong among all the participants in the healthcare environment. And so I have moved on from this angry patient stage. And I don't write about my anger. I don't speak about my anger. I tell my story, and then I tell what has been learned from it by myself and by the other people I'm around. And that's the kind of person you're looking for. You're looking to find someone else who can, or find someone to speak who has had an experience that gives them that platform, helps other people know that they have something important to say. So what you want to do then is find people who have had those experiences and then have gone beyond just the anger of the experience. I actually call them proactive survivors. These are people who have gotten through whatever their horrible experience was and have then taken that experience to make things better for other people. Regina, who's on our call today, who has also, she painted Dr. Renshaw's jacket. I also have a walking gallery jacket. I wish now I had put it on one of my slides, but Regina is someone who had a bad experience, a horrible, sad experience. But today, healthcare is better because she got involved, and they're the kind of people that you want to get involved with your organization. So some of the ways you can find those people. You might ask a patient advocate or representative who he or she found reasonable to work with, and then contact that person. And again, that would be someone who had a negative experience but felt as if they could move on and help other people with it. You might want to follow up with some of the patients who've had problems in your hospital. I do advise that you wait 6 months or longer, let them go through those stages of grief, maybe move on beyond their grief to acceptance, but see if you can turn the conversation about whatever their situation was into suggestions they might have. And if you approach them by saying, we know it was a bad situation for you, we're trying to improve what it is we're doing. Do you have suggestions that might help us move on and help other patients from now on? I also suggest you look for evangelists. Evangelists are people who specifically, again, have had some kind of an experience with your hospital, positive or negative. It doesn't have to be a negative one, who have great ideas for you and then want to go out and tell other people how they have contributed to what's going on in your hospital. I'll tell you what, you ask your marketing people, not just your quality people, but your marketing people about evangelists. Evangelists are going to be people who are volunteers in the hospital, maybe they're part of your foundation, any number of things that you can find evangelists for your hospital who not only provide input, but also tell the world about how good you are. And then, of course, maybe the most important topic of the day is to check SpeakerLink. SpeakerLink has an incredible number of these people, proactive survivors, and people like Dr. Renshaw, people who understand that bringing patients into the mix can help you in what it is you're doing. When you look on their listings, you can look for clues in their listings as to what their point of view are. If you read a listing and it sounds very negative, then the chances are that person is going to be very negative. But you'll see that most of those listings are not that. And those are people that you would be safe to call in and either to advise you or to speak to a group in your hospital or perhaps a larger group in your local area, even in your state, to help your group move forward in including patients in your work. But I think that's it. I think that's what I needed to say today. Matt, you're probably there. I'm certainly happy to answer any questions we might have after this.
Thanks very much, Tricia. At this point in time, I just wanted to go back and show some of the features of SpeakerLink. Now, as we've noted, SpeakerLink is developed by TMIT with great input from Regina Holliday, Tricia Torrey, many other patient advocates and people high up throughout the medical community. So the SpeakerLink itself is simply a compendium of users, of speakers who have signed up on their own, created their own profiles, and put themselves on the map, figuratively and literally, to show you where they are and what topics they could bring to help your organization or just to spread a particular message. So if we go forward in the slides, we can actually see some of the map feature of SpeakerLink so that you get a sense of when you search for a speaker. They're all over the United States. We even have a couple internationally as well, but mostly in the United States. And there's probably a speaker close to you. So there are a lot of folks that are high profile, that do national speaking, events and things like that. But if the concern is finding someone more locally, or if cost is an issue, if you click forward, you'll see that as you zoom in, there may be somebody really close to you in your community that is willing to engage with you right now. So if we click forward in the slides, you'll actually be able to see, just for an example, this is where our media team is out here on the West Coast in Southern California. And there's many different folks with all sorts of different backgrounds and things like that. So SpeakerLink is, again, just one of many tools that is out there. It's absolutely free to use. So there, it's not a product that we're out here selling you, but it is one of the things that is available to help find speakers. I found this presentation to be very useful. So I want to again thank Dr. Ramshaw and Tricia. And if we just had a couple of moments, just a couple of follow-up questions. Tricia, first, you emphasized the idea of listening to patients and hearing what they had to say. You gave some good tips as well to find those proactive survivors. Do you have any other tips as far as interviewing somebody? Let's say an organization did find somebody on SpeakerLink. The profile seemed like a good match for their organization. Any things that they can do when they go to contact them to make sure that they are a good fit for the organization, interview questions or things of that nature?
I think probably the key, Matt, is to make sure that whoever it is you're speaking to has a topic they can speak on that aligns with your goals for whatever the opportunity would be. So I can talk about specifically two opportunities that people who found me through SpeakerLink and then contacted me. In both cases, they were groups of QIOs. They were bringing in speakers to work with staff in the hospital. These were direct patient care staff. And they wanted to know some of the best ways to approach patients in the hospital, and specifically more about communications than actually about the medical care itself. What were some of the things they could do if a family member was sitting in the room, and so forth. And they had very specific outcomes that they were working toward, having to do with bed sores and falls, I believe it was, some of the goals that have been set for them through the Partnership for Patients. And they asked me what I knew about those things. And so I helped them know what I knew about those things. And they also said, well, we've got a few other documents we'd be willing to send you. And what you want to see is how collaborative that person is willing to be. Talk to them specifically about your goals. Ask them what experience they have speaking to those kinds of goals. In this case, what I said to them was, I really don't know anything about bed sores, and I really don't know much about falls. But what I can tell you is that I know a great deal about communication and motivating people to do what needs to be done to reach goals that are mutual. And actually, the slide I shared with you today was one of the slides I used in that presentation. Knowing that our goals are mutual, we should be able to find some ways to meet them together. And that was the approach I took. So be very upfront about what it is you hope to accomplish. See how well the person can answer your questions about what their experience is in that. And you'll have a sense from there, even if that person doesn't know everything they need to know at that point, you'll have a sense about whether or not they're going to be able to serve your purpose as well.
Thanks, Tricia. And Dr. Ramshaw, one follow-up question for you. I love the idea of PDSA and inserting the brainstorming. with the patients and the families in there. In that spirit of performance improvement, I'm wondering if you can tell us some of maybe the mistakes that you encountered early on, which became lessons learned, obviously, when you started to implement the model, integrating patients into clinical care.
Sure, and thanks again for the opportunity. Yeah, I think most of the mistakes are just things that you go through with good intentions and then find that maybe somebody isn't the right fit for this application. I think Tricia talked about it really well, you know, trying to get to know and assess this person's interests, what their perspective is. We certainly have had patients on our committees over the years that were still angry, still more focused on their problems than, you know, contributing to improve the overall process. And you want to have empathy and compassion for them, but it's a more productive group if you can get people, as Tricia said, that are focused on putting that energy and passion into improving for everyone rather than being angry with their situation. There's certainly a lot of people who are justified in their anger, but you want to have a group that's really focused on improving. And it can be very exciting to have patients come up with ideas. I can tell you in one of our quality improvement meetings, we had patients and a couple of patients and a family member look at some of our patient education around the hernia procedure and MASH, and boy, did they tear up the information. They really contributed a significant amount in our understanding of what it's like for a patient to read through patient education as part of a patient care process. And so, you know, we continue to learn. We continue to learn, and it's been a wonderful thing for me to go from where I was a surgeon and trained in the traditional environment and be able to learn and participate and share with patients and family members, and it's certainly humbled me a lot. And I'm sure we'll continue to make mistakes, but if you're open and honest and genuine, that's okay.
Thanks very much. Back to you, Chuck.
Well, this was a terrific session, and we've got ample time for Q&A. And what we'd like to do before we move to one of our reactors was Dan Ford, and a wonderful contributor on the national scene and speaker in healthcare. And he had a close friend with a medical emergency, so he actually gave us his comments and do's and don'ts and thoughts. So what we'll do is we'll poll this audience on these questions that you see on the screen before you right now in the lower right-hand corner of your screen, and we'd love to have everybody respond. And we're going to continue to have interaction with the speakers, and we'll loop back to the electronic healthcare record issue as well with a polling question that's really vital. Dr. Classen and I are speaking to a number of the top leaders in government, and regarding the flight simulator and CPOE, and Dr. Classen had to leave, that's why we put him up front. So we'd like to have you go to the lower right-hand corner, and you'll see the first polling question is regarding the first presentation. So everybody hang in there. We're going to come back to this patient engagement area. But the first question is, the electronic medical record and CPOE are a significant safety issue. We'd just like to confirm that it is of very high significance to our audience that are disproportionately quality leaders as we head into the next year. The number of medication and health information technology accidents is definitely on the rise, but we'd like to find out from you. The second question is, I would like more training on health information technology harm, errors, and simulation results. And that is on also on a scale of 1 to 10. We want to know from you if you want more information regarding electronic healthcare records, both for patients' access and the mainstream systems that are operating in our hospitals. We understand that there are just a whole lot of new opportunities for innovation there. That was the second question in the lower right-hand corner. And then the third question is, after deployment, simulation, and performance testing, is that important? So after deployment, simulation and performance testing is of value? And we'd like to know that question as well before we come back to the patient engagement issues. So lower right-hand corner of your screen, we'd like to have you respond to these polling questions, and then we'll share them. We'll share them with you as well as we are back up in January. The third or the next set of questions really tied to what we've been just talking about, and that is, what barriers do you experience in bringing patients into the healthcare setting? And this is a free text entry, so you can put in whatever barriers that you find. This is totally anonymous, but it'll really, really help us a lot to know how to address those barriers. Question number 5 is, what topics and solutions do you want our speakers to present? HIT, patient engagement, safety solutions, med reconciliation, for instance. And then question 6 is, what other topics and solutions do you want speakers to present? This really provides us some input for next year and allows us to make sure that, that each and every one of our webinars are hitting hot topics you really need help on, and that we can address them properly. And then number 7 is, what tools would be helpful in finding patient speakers? What tools would be helpful in finding patient speakers? So at the lower left-hand corner of your screen, please fill that out, including the speakers. That'll help us an enormous, to an enormous degree as we plan going forward. And as you all fill out those questions, what I'll do is, Matt, I'll go to Dan Ford's suggestions regarding speakers and his suggestions of the do's and don'ts, and I'll go through them quickly. And then I'd like to go back to each of our speakers, including Regina, and have them react to some of these ideas that Dan has put forth. So the do's are: be forthright, tell it like it is, your story will get attention. Ask and listen to what providers want us to cover. We could still work into our talk our own points of view, but not at the expense of totally ignoring the door-opening subject matter that we're asked to speak on. One of the big risks that we have is that a speaker might want to come in and just tell what they want to tell, and not necessarily what the quality or safety leader really wants them to come in and reinforce. So really listening. We talked about emotion, and it's great to have emotion. Being respectful is absolutely critical, and you heard that in Tricia's comments. We see that in her presentations and in so many of those that are on SpeakerLink, and having constructive input, absolutely key. And we've seen an A group and a B group. The A group are still going through that grieving process, and it's important that they have a catharsis and an opportunity to speak. But the most effective ones are in kind of the B group that have realized that they can give meaning to the loss of their loved one by helping us providers get focused on the things that we want to focus on. Being empathic, be part of the solution. And I think we heard this, Matt, and you can comment on this as well, is that we heard so many safety officers say, look, we've got lots of stories. We'd really like them to come in and help emphasize or underscore our solutions. Dan has a particular interest in inviting patients and family members into root cause analyses. And Dr. Ramshaw, would love to have you kind of react to that. So often we really feel like after a bad event occurs, we sequester the information, and we don't let patients and families who have been involved, at least involved in some way, and yet they have a major role. I loved what we heard about them interpreting who is delivering the majority of care, and love to have you come back and tell us about the revelations I think that we all have, that patients and families realize who's actually doing a lot of what the care is and the acting. Don't be woe is me and come in with the sad and tragic vignette. I think, we talked about the importance of positivity, and then just the really good things about any presenter, good eye contact, accept constructive criticism, and then develop a format. And Dan has done that and been really well received with his own presentations. And then finally, if you use PowerPoints, not too wordy, don't generalize in negative and harsh ways. don't name names for criticism. These are all really good suggestions, and you can see the theme of respect all the way through. Lots of ways of planting seeds. Maybe Dr. Ramshaw, do you want to kind of react to Dan's comments and give us maybe some further detail and insights on how we could be better speakers? And then number two, how can we really diffuse a little bit of this fear that our safety officers have of bringing someone in?
Yeah, I think it's a process to go through. You know, at first it's very uncomfortable to bring in patient and family members because you just don't know how they're going to react or respond. I think as speakers, I think I made the mistake too of trying to preach too much. That look, we have to do this change, and I didn't understand what was mentioned in these do's and don'ts. That these providers, these administrators, they really care and they're really trying hard. It's just a very, very complex system with a lot of challenges, and the great majority of people in our healthcare system truly passionately care and they want to do their best. And so rather than looking at it in divisiveness and fragments, realize, again, we're all in the same boat, and not get too frustrated when you don't see change or you don't see the kind of response that you would like. Look at it with empathy and realize the situations that they're in, whether it's a patient or whether it's a hospital vice president or CEO. And we really are in all this together, and if we can work together and share experiences and listen, listening is another important part of this as you go through this process. I think it gets more fun and easier to implement.
Fantastic. Tricia, and then Regina.
I think what I would like to focus on is something that Dr. Ramshaw has said and also that Dan Ford put forth, and that is the word respect. One of the things that when you interview a potential patient or a family who might come in and talk to you, you can hear whether or not they are respectful of what it is you're doing, and they can hear whether or not you're respectful of them and their experience. And I think that once you establish that mutual respect, then the conversation about what will serve your purposes, what will serve their purposes, and how you manage each other's expectations is just vital. I think that's so important. But it's, you know, respect is something that is so hard to get our arms around, but we absolutely know it when we see it and hear it. And I think that that's a great starting place for when you have a conversation with someone about the potential of working with you.
And Tricia, real quick, if somebody were to reach out to someone on SpeakerLink, and we know so many of the almost 200 speakers that are on there, just because they've contacted them doesn't guarantee they'll have them come in and speak. I think all of the speakers are just willing to visit with patient safety officers, administrators, and directors to get a feel for them, and I think they're very approachable. One of the reasons they're on there is that they're pretty approachable. Is a fair statement?
I would absolutely agree, Chuck, and I would go further and say I do get calls. People reach out to me, and quite often I know I'm not the right person to help them out, but I have such a network of friends, as does Regina. All of us do, and if you have something in mind that you're looking for, we can maybe save you the time of having to weed through everybody who's there and suggest other people for you to call, and they're probably on SpeakerLink already. So absolutely, I would say that's true, Chuck.
Fantastic. Regina, your thoughts reacting to everything? We may have lost Regina. I'm going to come back. Matt,
I'm here.
Oh, okay, Regina. Go ahead. Were you muted? Go ahead.
Sorry. Yeah, I was basically saying that I'm so excited because we started with computer technology and what the safeguards can become in place using CPOE, and then we went into patients and what they can do, which is just amazing because what both groups, whether you be a patient that comes into an institution or a computer program that comes to an institution, we come with a different set of eyes. We come looking at the problem from a completely different worldview, an unbiased oftentimes worldview, something that adds to the conversation in a new, wonderful way and creates a great partnership. the thing like Tricia Torrey and myself and Bruce, we all travel greatly. And that's one of the wonderful benefits of bringing one of us into an organization, a quality initiative, is that we have been at so many places and can activate our network, what's happening regionally, what's happening nationally and internationally, and provide the kind of information that folks need to realize, hey, maybe we had never thought of that solution to this problem. It could be something that would work at our institution. And it just invigorates people. It makes them want to change the world.
Well, I think it's true, and I brought us back to the slide that we started with at the beginning. And this slide that you see before you, those that are still on, the medication use process, I want to draw your attention to the fact that we now know where errors occur, and we now know where harm occurs. And not every error causes harm, and not every harmful event is because of a typical, what we would call error. And I want to take us right to the patient. When you go right down to administration, down right here at the bottom of the slide, this is the interaction with the patient and the family. The opportunity for us to train patients and families to really watch out for the things, as Dr. Ramshaw said, you know, these are complex adaptive systems, and patients and families can have an enormous role to prevent harm that can occur in the acute care inpatient environment. But 80% of care is outpatient. The moment that those patients leave the doctor's office, the hospital, the outpatient center, there are 90 million Americans today that are caring for someone else, and they are their medication manager. They are their wound care person. They're the only person in the middle of the night that is the pain care manager. And I think really as hospitals start to buy up practices and expand, all we hear today is consolidation, narrow networks, providers network systems. And we don't hear a lot about getting patients and families to be co-designers with us. And maybe Dr. Ramshaw, come back to you. After you undertake surgery on a patient, these days, more and more of the care, convalescence, and healing is in the home. And isn't there a great opportunity for us to get patients and families engaged in the whole episode of care, to, you know, when they come back to see you for the first visit, and you know, and after they leave where they have their operation? Is there not a great opportunity for us to get patients and families to be co-designers of the continuum?
Yeah, absolutely. And it's so critical to think beyond just the walls of the hospital. You know, for traditional physicians and hospitals, you really focus on that clinic visit or that time in the hospital, but there's so much that happens outside the hospital. And as we evolved to this team approach, and particularly with the patient care managers, soon after we began the model almost 10 years ago, I started to hear things from our patient care managers that I couldn't believe, and they were hearing things from the patient and family at home that I never even heard before. And as we continue to improve process and develop the entire cycle of care, it's more and more important to not just kind of leave that to the patient by themselves, but to listen to them, to address the issues. Recently, we've implemented a pain management part of some of our processes, and some of the patients are getting out of the hospital post-op day 1, where they used to be in 4, 5, 6, 7, 8, 9, 10 days with a longer-term local anesthetic block. But when the block wears off and they're at home at 2 and 3 days, they start to have pain. If we didn't have a patient care manager and continuous interaction, they'd end up in the ER all the time. But with the patient care manager, with the whole cycle of care planned out and the patient understanding what's going on, we don't get that fear and that concern that something's wrong. So that's just one example, but it's absolutely important to look at the whole cycle of care, involve the patient, listen to the patient, what goes on, and then apply that knowledge to improving.
Fantastic. Tora, I know,
Josh,
Chris,
this is Tricia.
Yeah, I was going to come right to you because you have a lot of experience here. Yeah, go ahead.
I was just going to say, it's actually a simple concept if you think of it in terms of a preposition. And so typically, for maybe at least the last 50 or 75 years, medicine has been something that has been done to or for patients. and the medical world has felt as if they need to do everything. Well, you know, that's hardly fair to leave everything on the shoulders of the medical world, particularly when they're not with patients for most of their lives. And so what I like to do is emphasize the word with. So no longer should it just be 2 or 4. Medicine should be done with patients. Patients as a pivotal part of that team, and their families or caregivers as a pivotal part of that team, knowing that they're the ones on the front lines. And I also think that it's a lot about managing expectations in both directions. Patients need to learn how to manage expectations of their providers and their caregivers to say, you know, when I get home, I don't have anyone who's going to be able to help me do X. And in the meantime, providers need to be managing patients' expectations. So what Bruce said about the patient gets home 3 or 4 days post-op and says, wait a minute, now I'm in pain. Well, if they've been told, you know what, in about 3 days you're going to begin to feel some pain you haven't felt until then. If you do, then these are some things you can do to take care of it, and this is the point at which you should be calling us. And if you give it to them in by voice, and if you give it to them in writing, and maybe even have a website where they can go to learn more about it, well, now everybody's expectations have been managed, and they don't show up in the ER.
Thank you, Tricia. And as we go to Matt, Colin, and Mira, do you all have comments? I think we spend an awful lot of time designing what we are rolling out now, which will be called Care University. And our partners in this initiative are Google and Sesame Street and the World Health Organization, Mayo Clinic, Cleveland Clinic, Harvard-affiliated hospitals. And we will be rolling out training, which is a real lifeline modules to help the caregivers reach out across this gap that we have, and the family members to reach their caregivers. And it's great to see how you've done things, Dr. Ramshai. And I think as we go forward, we're actually going to have to build bridges, and there won't be money to spend on those bridges. So we really need to bring our shoulders to the wheel in doing that. Matt, Colin, Amira, anything you'd like to comment on as we think about as we go forward?
I think that's a great opportunity for more and more partnerships. The Care University model that we're building is going to be a very necessary component to teaching patients. It can be a great opportunity to teach patients, and as we get there, we're going to need the great input and a lot of the programs and the learnings from safety leaders, like the audience that we have on this call, and our network of great clinicians and providers out there that can give us the information that patients need, as well as listening to the patients and understanding what they need in the healthcare setting as well, because both sides of the coin are extremely important here. So as we build out Care University, which will provide modularized learning for people all across the healthcare spectrum, we're going to need input from you guys. And and when I say you guys, I mean everyone, both the people that are receiving care and the people that are providing the care, and everything in between, because that's how we're going to build the robust educational material that can really fix a lot of the issues that we have in healthcare, or at least provide information when you do run into a problem. And so that's our hope with Care University.
Fantastic. Is Colin on the mic?
No, he's away from the mic right now.
Okay. So as we go forward, I think, Tricia, you made a great point. We've been doing things to and for patients. And our goal really is to be training caregivers to formalize their approach of partnering with patients and families, not because it's a good idea, which we all think it is. It's a vital idea. I mean, it is a life-saving issue. And we're not trained in medical school and pharmacy school and nursing school and in the traditional format to really engage as a teammate with the family. But the average, what we call care mom in America, care mom or care dad, average age 47, 70% are women, have someone they're caring for that's an elderly person that has more than 5 or 6 meds. They're also caregiving for a family, at least 2 other people, and they're actually having to make care decisions for younger people that are in school. And this average aged 47 individual is using a smartphone. So I think there's a huge opportunity coming back now to you, Regina, with the passion you have for IT, opening up IT, making medical records available, and using applications that actually can have us kind of connect the dots. Regina, don't you hear in the meetings that you're in that there seems to be less and less fear with transparency? There appear to be less potential disasters that everyone would say the sky is going to fall in when you let patients and families have their medical records. And I just don't see a rise in malpractice or the other things that were the boogeyman in the closet.
Yeah, it's amazing how mobile health and the fact that we have so much smartphone adoption has really changed so much in the last 4 years. There is truly now a belief that involving patients, having them have data access, is now becoming a reality, not just from government officials, but from people at hospitals all over the nation.
Fantastic. The one thing that we're a little concerned about is adopting these new technologies. However, we've got a real rash of accidents that are occurring because we've got residents and we've got doctors in training and even doctors that are moving fast, using the health record as something that allows them to substitute it for the time listening and talking to patients. And so one of the things we hope is that you as an audience will help affirm for us the concern about health information technology and the fact that we've really got to focus heavily now on the unintended consequences of using these technologies so they don't backfire. We're really seeing a rash of things because of these. And Dr. Ramshaw, do you see kind of on one hand the great benefit of IT, on the other hand really having to be careful and not just using the pull downs and copy and pasting the medical record and letting that substitute interacting with the patient and the family?
Yes, I think it's a critical issue, and again, I think more and more people are recognizing that, you know, the move to electronic medical records is great. It's good. It's a good thing to do, but it's not good enough to just say we've moved to electronic medical records. We're going through that first early phase of learning that, you know, just having electronic medical records is not the goal. The goal is to get to the point where we're having that information be really owned and accessed in real time, anytime by the patient first, and also have that electronic medical record add value. And as you said, we've learned there's lots of problems, there's lots of errors, and there's lots of inefficiencies with the first generation. But that doesn't mean we can't have a second, third, fourth generation and continue to improve. Ideally, and coming from complex system science, you will need to design around the patient process and definable patient processes. And when the electronic medical records are defined around definable patient processes and simplified, then the efficiencies and the quality can get better and better. But ultimately, the patient should always have access to their own electronic medical record. And so I see we're just in the first generation, and as we learn, we can apply that knowledge and get better and better and better.
Well, thank you. I want to thank all of our participants, our speakers, our reactors. Our prayers go out to Dan Ford, one of our steadfast supporters. He's every other Saturday morning he's on with a group of patients and families that are really working with us on all of the things we're doing, SpeakerLink, Care University, and the rest. I'm going to close and then with a couple of slides to introduce what we're covering next year in the first webinar. And then we'll go to Regina Holliday and allow her to give the last 30 seconds. We always want to start by setting the tone of why we're here. And then I'd like the speakers and reactors just to stay on for a minute for a rapid process improvement loop to make sure we can do things better next time. So the last two slides are really as we move from the current fee-for-service curve, this volume-driven, transactional, fragmented health system where, as Tricia said, we're doing things for patients and not with them, and we move to the accountable care curve where the driver's not volume, the driver is value. This is a huge leap. And what we addressed in a recent webinar and in some national speeches is the fact that this really is a zone of disruption, but a zone of innovation. This is our opportunity to have a huge impact, and this is where the arena that we're playing in right now, where we really, really need to build the bridges. And as we do that, and we look at infections, which we're going to cover in the first webinar this coming year, and we'll have the Cleveland Clinic on and discuss this issue of consolidation. As we're enlarging our footprint and buying practices and hospitals are folded in, safety and quality officers are at enormous risk of having to be responsible for a standard of care that may be below, maybe above, but could be below where they are. So as we look at new procedures like imaging departments and surgical centers and other facilities that don't have the infrastructure that we do at a big center, we really need to be aware of the infection prevention upstream and infection detection downstream. And so we'll have speakers in our first two webinars in January and February help us understand what's under the iceberg, under the waterline, as Dr. Ramshaw used the metaphor. There's so much under the waterline that is very risky, and we can have a enormous impact on saving lives, saving suffering, and preventing these terrible things that happen when we're trying to do good for patients, but then we give them infections. So that's what we'll be covering in January, and February we'll have topics as well. Regina, would you close us with just a closing statement, and then we'd like to keep everybody on just for 5 minutes. And we hope you have a blessed holiday. And again, our prayers and thoughts go out to all of those who are suffering today, and especially Dan Ford, who couldn't be with us.
Well, I'm honored to close the year's webinar. We have done such amazing things in the patient community, with the TMIT community. Everything is moving forward at such a fast pace, and my prayer and hope going into 2014 is we continue at this pace, we continue this momentum toward great change. Thank you. Bless you all for all the amazing work that you've done this past year and in the years to come.
So we hope you all have a wonderful holiday season, and we'll see you in 2014.